of mode during the session. Feedback form will be available at the chat box after the completion of the program. E-certificate will be mailed to all the participants through their registered email ID after submitting the feedback form. Now moving ahead, I request Mr. B.R. Shekhar to deliver a welcome address and brief us about the program. Sir is the president of All Indian Association of Medical Social Work Professionals and currently working as Chief MSSO in New Delhi. He is a compassionate healthcare professional with 30 years of experience in medical social work. He is an alumnus of Department of Social Work, University of Delhi. He is also a president of AIMS Medical Social Service Officers Association. He is a nodal officer of Authorization Committee and also a member of various other committees. To his exemplary contribution in his introduction of CSR in AIMS under his leadership, he has worked diligently during the COVID-19 pandemic and arranged various resources single-handedly. Now I'd like you to connect to Shekhar sir. Sir, please.
Mr. Irfan Sheikh, please stop sharing your.
Thank you, Kirti. Thank you.
No, sir, 1 second before you start. There's someone else. Okay, sir. Thank you.
Dr. Ali, thank you. Shall we start?
Yes, start, please.
Okay, thank you. Good evening, everyone. I am B.R. Shekhar, President of All India Association of Medical Social Profession. I am working in All India Association of Medical Sources, All India Association of Medical Sciences, New Delhi, as Chief Medical Social Service Officer. I am delighted to have this opportunity to extend my immense pleasure to welcome all the eminent panelists and the participant of to the 5th International Panel Discussion of All India Association of Medical Social Profession, South Zone, in collaboration with Kerala Association of Professional Social Workers on social work, healthcare during pandemic, India and global. Today, in this panel, we have eminent speaker, Dr. N. Lina Redemaker, specialist in the German Association for Social Work in Healthcare, Germany. Ms. Angela Tonge, social worker from Advanced ICU Alexander Hospital, Brisbane, Australia. And we have Dr. Anil Goswami, additional professor from AIMS New Delhi, where we will be discussing in strategy implemented in these crisis in Indian and global perspective, and how we medical social work profession can advise or support and expand our vision behind this threat. A vision of better respect and sustainable society, a vision where our social system can actively eradicate the condition that have lead to disease outbreak in the context of the climate change and poverty. Seeking the current scenario, it's essential to have the supported, equipped, empowered, and protecting healthcare profession workforce to mitigate the damage effect of COVID-19. We can build our exciting, strong tie to children, family, and community to critically respond effectively way. How we do so, we must stay safe and healthy. As we the front liner have essential role of COVID-19 response, including preventive and responsive role. As a promotive, we have to educate, coordinate, educate, clean, manage, and monitor to keep ourselves and community safe. As a preventive measure, we have to identify the vulnerable population, provide psychological support, reinforce gatekeeping, and carry out the contact tracing. As a responsive role, we have to equip and provide protective protection and support to the vulnerable population, identify emergency and alternative care options for the children and the patient. We need to carry out the case management process, assessment, planning, referral, etc. Provide the supervised psychological support, provide medical support, food and medication to the patient, manage physical assistance, and provide regular counseling. As as you know here, that our working in names, we have a dedicated team of 50 medical staff who work in a different department and center for the patient welfare services. We also run our services in emergency department 24 into 7, which is unique in our country, where we provide the support and service to the patient, including counseling, psychosocial support, financial assistance for harassment and transportation to the patient during the lockdown. CSR, we have mass order here to distribute food for the vulnerable population and raise fund for the PP kit and other equipment. We did also awareness campaign and advocated patient coming to the hospital. We also work closely with the hospital action control management to control the infection among healthcare workers. Now, world is different, and every country has its own set of challenges. Every crisis offers an opportunity to revisit our priorities. The COVID-19 crisis involved lessons for each one of us to reflect holistically and comprehend.
बंद कर अच्छे से नहीं जाता अरे कोई बात नहीं हम तुझे काटना है लगा आउट कर दिया आने दीजिए आवाज आ रही है नहीं बंद बोल दीजिएगा नहीं को किसी और
Dr. I.T. His General Secretary talks. Wishing good health for everyone. Stay safe. Thank you. Thank you very much. Over to KP.
Thank you. Thank you, sir, for your welcome and greeting the session. And now moving ahead, I would like to hand over the session to Dr. Anish K.R., Vice President of Kerala Association of Professional Social Workers, to be the moderator of the session. Dr. Anish is currently working as Assistant Professor, Rajagiri College of Social Science and former Head of the Department of Social Work. He has 21 years of experience in social work practice, research and training. Teaching. Dr. Anish completed his MSW from SSUS, MPhil from NIMHANS, Bangalore, and doctoral degree from MG University. He has been an exchange faculty to University of Utah, USA, has received several grants for research from different funding organizations such as Australia Indian Council, Australia on Health Social Work, German Academic Exchange Program, UGC, ICSR, IMPRESS, and Government of Kerala. He has a number of publications to his credit, with recent one on health social work in India in International Journal Social Work in Healthcare. He is also a Vice President of Association of Schools of Social Work in India. He is also serving as a Chairman of Board of Studies of Mahatma Gandhi and Kannur University in Kerala. Now I will connect you to Dr. Anish, who can take the session from here.
Thank you, Kirti.
Thank you, sir.
And let me take this opportunity to welcome you all to this international panel discussion on health social work. Now, we know that uh, today's statistics says 14.1 million people are affected by COVID-19 all over the world. And India contributes this statistics by 1.04 million. And every day we hear news of increasing COVID-19 in our country or as well as across the world. Now we stand third in terms of the total number of patients with COVID-19. Now, health social work is not a celebrated profession in that way, though we play a role in the front line, but still not very much celebrated. But today's panel discussion is on how we look at health social work from the perspective of a global as well as Indian perspective. So we have eminent speakers in front of us. So I won't take any more time. Let me introduce the first speaker and we'll start with the presenter. And each speaker will speak for 15 minutes. And after 45 minutes of the three presenters' presentations, then we will go for a discussion and we would prefer you to put your questions in the chat box so that we can consolidate the questions and uh, take that to the speakers. And kindly ask, Dr. Kirti has already informed you, please keep your mic muted and kindly please do not share, present your screens while while the speakers are speaking. Thank you for your cooperation and support. We'll start. Let me introduce our first speaker, Ms. Angela Tong. She is a clinical team leader and advanced social work practitioner at the Intensive Care Unit, Princess Alexandra Hospital, Brisbane, Australia, where she has worked for over 20 years. Ms. Tong has practiced social work in both adult and pediatric healthcare settings in Australia and Ireland, and has published in the areas of social work, clinical ethics, and the needs of families and of trauma ICU patients, and on the development of healthcare practices model for hospital social work in India. She specializes in grief and loss, bereavement, care and support, crisis intervention, psychological first aid, and disaster management. She has developed an interest in communication skills training for medical practitioners in critical care specialties and also provides strategic and clinical leadership in her hospital's response to domestic and family violence. Now, I take this opportunity to welcome Ms. Angela Tong for her interesting session. Over to you, Dr. Angela.
Thank you very much, Anish. Can you hear me?
Yes, yes.
I'm just trying to get my slides up here. So are you able to see my slides?
Yet to see it.
Yet to see it. Can you see it, yes? cases have increased since mid-June, with some very worrying signs currently happening in the state of Victoria, where there seems to be lots of clusters and a rather scary feeling that our wave is heading our way. I live up in Queensland, which is further up north, where we've been seem to have managed quite well so far, but I feel that I'm speaking too early and there is worrying signs coming our way. Of the cases with a reported place of acquisition, 45% of those who have acquired COVID-19 have recent international travel history, including over 1,300 cases associated with cruise ships. So that's quite a lot that started our wave in early March, coming off cruise ships. Next slide, please, Anish. Thank you. So I just wanted to talk to you also about who manages the response in Australia. States and territories, we've got 6 states and 2 territories. Those governments are responsible for health matters, but where there's a serious issue or pandemic such as what we've got now, the federal government becomes involved. So those levels of government have a Australian Health Protection Principal Committee which makes key decisions and coordinates responses. They meet daily to assess the risk to Australia and recommend the public health actions that need to occur. Next. So what are we doing? What's our response been? We have applied, obviously, travel restrictions. Various states have closed states and territories have closed their borders, closed to international travel, ensuring that any travellers do quarantine on arrival, that there is border surveillance, a rather large economic support package, a health package to ensure that our healthcare systems are able to manage the surge of patients that we have anticipated, an expansion of telehealth services, support to Australians experiencing domestic and family violence. We know from research and statistics that during not only disasters, but as it turns out, pandemics, a rather large increase in those experiencing domestic and family violence. Money invested into mental health and wellbeing response, quite a large amount of money invested in that. Programs such as home-delivered medications, securing face masks and personal protective equipment for medical professionals. That was quite a concern very early on when there was looking like possibly being a shortage, and that was a real fear for staff in the hospital that they wouldn't have that equipment and the risks that they would put their family and themselves under. We obviously do contact tracing for coronavirus cases, testing people who are suspected of having the virus and monitoring those close contacts of confirmed cases as well. There's been fever clinics that have been opened. The federal government has released a COVID-19 Safe app, which is designed to help make contact tracing a lot easier. There's been school closures and sporting events. You can see the picture of the cricket, which I thought you might respond to. They haven't quite cancelled the cricket season yet, which I'm glad because we're due to play India, but they've certainly curtailed a lot of major sporting events, which is something that's very big in Australia. So what did we do in our hospital to prepare for what we knew, what was coming, what we could see happening around the world? Our hospital was prepared for what they call staged admissions. So our intensive care unit, as it currently stands, has 30 beds, and we were looking at expanding those to intensive care beds. So that obviously requires lots of planning, but that was going to be staged. So from 26 beds and then a further 20 beds, and so on and so forth as the need arose. We also needed to develop or look at different policies and indicators for this pandemic. So for social work in our hospital, we are responsible for viewings of deceased patients. So I had input into management of deceased patients and viewings when they were to occur under COVID conditions, what procedures would be if there was mortuary overflow. And we had restrictions put on visitors to the hospital as well, so social work had input into that procedure. We had to also deal with business continuity, so the hospital still needed to run, we did a large amount of elective surgeries very quickly to get that out of the way, to allow for if there was to be a surge of COVID patients coming to the hospital. And we also needed to look at things like staffing vulnerability, so people who would be able to turn up to work, would want to turn up to work in a pandemic. We needed to look at, you can imagine with an increase from 26 to 72 beds, that required new ventilators to be purchased, staff to be upskilled and trained in the use of PPE and in dealing with people with coronavirus. From a medical point of view, the pandemic also required planning around clinical ethics and a guide to ethical decision making. We're looking at intensive care bed being perhaps more needs than what was able to be supplied. So medical staff really having to make some very hard decisions about who actually would get an intensive care bed and who would not. From a social work point of view, our intensive care unit was having meetings twice a week in the planning for this pandemic, and as the social worker in intensive care, I was made responsible for sorry, interrupted the I'll just keep going. I was made responsible for the wellbeing profile for the intensive care unit. So what we actually established was what was called an intensive care kindness group, and we were able to develop a framework for staff support which encompassed strategies for ensuring that staff had access to formal and informal supports in order to manage their mental health and their psychological wellbeing. Practicing things such as gratitude was a primary focus of this group. It was important to acknowledge that through simple and genuine expressions of gratitude, the commitment of staff that they were demonstrating and their willingness to put themselves in harm's way for their patients and their colleagues was really important to acknowledge. The group also encouraged staff to take some additional steps to support their wellbeing by developing a wellbeing plan, and the aim of this was to help some staff to be and remain as healthy as they could be during these challenging times, and that way they would want to turn up to work. We know from, again, the literature that staffing rates decrease quite significantly in disasters and pandemics. You can expect to lose 25% which occur in the workplace, such as this pandemic. Emotional support through intentional acts of kindness has been shown to alleviate stress and energise the spirit. So we developed some little bags, which you'll see on the right-hand side of the slide there, that had coffee batches in it, chocolates, a pen, and some supportive messages. We also put in the individual rooms around the intensive care unit some door signs or just messages of support that say, thanks very much for turning up to work today, keep up the good work, you're the best, those kind of things. It's pretty tough being in that COVID room with all of the PPE equipment on. It gets very hot, and staff are really under very trying conditions, so they really need to know that others have their back. Next slide, please, Anish. One of the other things that was really critical for me as the social worker preparing for this, and as we received COVID patients, was ensuring that communication was really important, particularly to these families. We had time to prepare by setting up various platforms on iPads. Families weren't able to visit, so we needed to have some way of communicating that. That became the primary role for social work as a clinical communicator, and I could talk to these families twice a day and send them pictures of their family member, or send them video footage of their family member, or make video calls where they could see the doctor, they could see the environment where their family member was. I was also involved in developing scripts for compassionate conversations. So that was to do with when we knew that we couldn't communicate with people face to face, which is what we normally do, a lot of communication was going to have to be done over the telephone to families who were not able to visit, not able to see, and not knowing what was going on minute to minute, hour to hour. So it was really a one-page document that gave the medical staff a script about how to communicate with these families in a compassionate way. And obviously education was also part of it. So the little picture on the right-hand side there that says, how do we communicate when there can be no visitors? That was a podcast that I had done about communication, which you're more than welcome to access and listen to. So again, from a social work perspective, what I was doing really was the principles involved in psychological first aid. Contact engagement was my major strategy for dealing with these families, because again, they were often isolated at home themselves, because they'd been in close contact with someone who was COVID positive. They were also required to isolate. So it was important for them. A very common story among these family members was really not knowing what was occurring with their family members. So that contact that came from social work was absolutely vital. And one of my families at the end commented that through the contact with me and what we were able to do, they felt that that was quite life-saving, and that was a really powerful thing for me to hear. Sorry, that slide's come off a bit. So again, I initiated contact with these families twice a day, gave them either might have had a nurse with me, gave them a clinical update in the morning and the evening. We know our intensive care patients' families like to know what's happened overnight and like to know what's happened just before they try and go to bed each day, and where I could send them video footage or photographs, and I absolutely would. Stabilisation is another principle of psychological first aid. So counselling provided to families to keep them calm, orientate them to the environment where their loved one was. The mental health that they experience is really concerning. Again, it's that not seeing and that not knowing and the isolation which really wreaks havoc with these families' mental health. So there was a lot of feelings expressed with anxiety and fear and some really strong emotions. It was important from a social work perspective to provide safety and comfort.
Angela, you have 1 more minute.
Okay, I can do that, Anish. So safety and comfort, being able to provide the current update, as I said, the counselling, the reassurance. The practical assistance was quite important. Australia, the different states had travel restrictions in place, which needed to be negotiated to either help families to be able to travel or to repatriate deceased patients home. The last main strategy for the psychological first aid was about linking families to support. So our patients, their families were either all over the country or in other countries as well. So that's where platforms such as Facebook Messenger worked out extremely well for us in terms of managing our patients. Anish, that should hopefully keep me right on time. So thank you very much.
Keep your questions ready for posting in the chat box. Now I will go to the next presenter. It's Dr. Anil Kumar Goswami. Has been working in All India Institute of Medical Sciences, New Delhi since 1982. In the medical social service cadre and teaching health education since 1995. He completed his MSW in 1979 from Jamia Millia University and is currently working as additional professor at Center for Community Medicine, All India Institute of Medical Sciences. He is a founder, general secretary of All India Association of Medical Social Professionals and patron of the association. He holds the responsibility of National Service Scheme at AIMS since 1992. He has contributed in various disaster relief activities under National Service Scheme. He was the treasurer of All India Association of Preventive and Social Medicine from April 2017 to March 2018. He is the Nodal Officer for Disease Prevention and Outbreak Response Cell of AIMS New Delhi. Dr. Goswami's area of interest are social welfare, health education, health promotion, care of elderly, community organization, and health and human rights. He has published several research papers in national and international journals. Now over to you, Dr. Anil Goswami.
Thank you, Dr. Anish, for introducing me. Good evening all, and I welcome all the viewers. And I'll start my presentation from Dr. Anish. Can you please show the first slide, please?
Let me present it. Yes, sir.
Well, it's a very great opportunity to talk to you all on the social work in healthcare during pandemic, and as far as Indian and global perspective is concerned. Next, please. You know, the COVID has been the biggest crisis with humanity since World War II, and it has already cost us more than 10 million or 14 million cases and around 7 lakh deaths and countless livelihood worldwide. The impact of economy has been extremely sharp. Now, we have been proactive in assessing and dealing with the challenges caused by this pandemic, and saving lives have been our foremost priority. While our caseload continues to be high, and we have fared comparatively better than many of the countries with low death rate and with high recovery rate. And this can be attributed to early steps to protect people. Now, government has channeled various public resources to the healthcare sector for, development of the hospital, emergency rooms, provision of equipments and supply, and training of healthcare professionals. As this was totally the new disease, so many of the new arrangements have to be made from the starting point. Next, please. The risk of death from coronavirus disease is higher for men, old people, and people with greater deprivation. In one of the UK study, it was noted that most deprived people were 1.8 times more likely than the least deprived to die with COVID. And people 80 years and older had 24 increased risk of death compared to 50 to 59 years of old of people. Then uh, the death rate, men carry 3 times higher risk of death from COVID than the women. Next, please. Next, please. Data from a US study has reported that people with chronic diseases like heart disease, diabetes, they are 12 times more likely to die as compared to uh, 6 times more likely to be hospitalized as compared to healthy person. So it seems that people with chronic morbidities, they are at more risk as compared to other healthy persons. So around 20% of the patient with underlying diseases died compared to 1.6% of those who are healthy. And Indian data has shown that hypertension was the most common pre-existing condition, followed by diabetes, liver disease, heart disease, asthma, and chronic renal failure. And it has also been seen that people who are 60 years and over, they account 53% of the COVID death in India. Next, please. So, to deal with the economic challenge posed by this pandemic, PM Narendra Modi initiated a forward-looking economic approach under the title Atmanirbhar Bharat Abhiyan. A package of nearly 20 lakh crores has been given to provide the social safety network to the vulnerable section. The vision of Atmanirbhar will stand on the 5 pillars, and India has tried to live up to the teaching of seeing the world as one family, that is Vasudeva Kutam, by sharing medicine to more than 120 countries while also keeping interest of our population. Next, please. So the first COVID case was reported on 30th January 2020, but clinical, epidemiological, and laboratory knowledge control of coronavirus indicate that humankind will have to live with this virus. It's not going to be end very soon. The case fatality rate in India has been relatively on the lower side, and mostly it's limited to the high risk group of elderly population and those with pre-existing conditions or comorbidity. Though India's nationwide lockdown from 25th March 2020 till May 30th has been one of the most stringent, and yet COVID cases increased exponentially through this phase from 606 cases on 25th March to about 1,81,000 on 30th March. Next, please. Next. Now, the biggest question and answer to COVID-19 is, the first question is, are we testing enough? There is no straight answer. At this moment, India is testing about 9,500 per million population as compared to 1,28,000 Spain, 82,000 Germany, 38,000 France, and about 1 lakh for Italy. As India's population is around 10 to 12 times bigger, so this testing is or can't be enough. Dr. Swaminathan, the chief scientist, says that India needs to expand its testing by more numbers, and unless the prevalence is less than 5%, it should keep on increasing and increasing. And it should be in the whole country and also in the hotspot areas. Secondly, are we in community transmission? With more than 10 lakh cases and a growing rate of more than 34,000 new cases per day, it is hard to believe we are not. Independent experts say we are, but ICMR chief disagree and say India is not in the community transmission. The ICMR former head of epidemiology, Dr. Raman Ganga Kedkar, preferred to call it local transmission. His reason was not unconvincing. As he said, it's not happening all over the country. In fact, 80% of our cases are in just 49 districts. So perhaps it is very much right to call it a local transmission. Next, please. Now, according to Indian government, 80% of the active cases are from 49 of the 720 districts, and these form about 7% of the districts. So, how significant is our mortality rate? At about 10 per million, it's better than UK's 658, Italy's 578, and Spain's 407. And that's why our government claims we are doing better than many other countries. Next, please. People over the age of 45 years, who form 25% of the country's population, account for 84% of the COVID deaths. And it is asserted the country has been able to manage outbreak relatively well, and it is lowest in the world. So, India saw largest single spike with 34,000 new cases and 677 deaths yesterday. So on Friday night, yesterday, more than 10 lakh confirmed cases were reported as far as India is concerned. Next, please. Then what is the role of medical social work in healthcare? So we have to be very much self-educated as far as the disease is concerned. What are the symptoms? What are the different, testing tests, and whether there is any treatment or not, whether vaccine is not, and at what level the new development of vaccine is currently going on. Then what are the preventive measures? So we should be all educated enough to communicate the right information to the patient or to the community. So naturally, by doing this work, we will be experiencing stress and fear, and maybe experiencing many false news and wrong information, for which we have to clear the doubts of the people. And this is our one of the role. Then we need to incorporate medical social workers initiatives at all the intervention level. We have to educate people about the various myths. Now, daily one or the other myth is coming in the media, whether one should take non-veg or not, or whether yoga is good or bad, or whether adrak or haldi, all these things, help in preventing the disease. So we have to clear. So most of the things are good, as far as immunity increasing is concerned, but these are not directly related for the prevention of the disease. So we have to also connect to the local, state, or national authorities to involve our discipline in more and more stages or level. Next, please. So we have to also take care of the working environment in the hospital and premises, because many a time it has been seen that the hospital infection is very common or very prevalent. So we have to also make ourselves understood as far as hospital infection is controlled. What are the different methods or measures by which we can control the infection at the household level, or in the office level, or at the hospital level? So there's no doubt with this epidemic, even some of the staff members are also being suffered, and there is a shortage of staff. So rest of the people are also experiencing increased load. Anyway, we have to face it, and we have to accept it very with interest and very courage. So the main role of we people is also in counseling and providing psychological support, because if the patient is admitted in the private ward or in any hospital or COVID hospital, so he is not allowed to meet to the family members, and no patient is being provided for this help. So to make some communication skills, we have to use, and we have to provide the message of their family members to the patient, and you know, the status of the patient to the family members, so that they are not in panic situation, or their anxiety is, you know, to some extent resolved. Then we have to also help in tracing, as far as tracing is concerned, because we are the best people as far as community involvement is concerned. So we have to work in community tracing, and also in testing, and also providing the support, whatever is required to the community people. We have to also keep track of the hotspot in the nearby hospital. We have to also locate people telephonically, and we have to also listen about, okay, what are their problems, and we have to tell them the solutions. Next, please. Next slide, please. Now, challenges faced by the medical social worker are many as far as telehealth services are concerned, because many things we have to learn at the new level. So medical social work, they have to also provide some. They will also you know, have some extra roles and responsibility to meet this additional need at the time of COVID. Next, please. So counselor, the challenging job in pandemic of by you know, by the medical social work professional, maybe counselor may have to help home isolation patient. Now this is a big challenge, because now the government is also trying to put the patient who are very mild asymptomatic, and not having even other signs, to put the patient in home isolation if their report is positive. So they should also follow. We should advise them if they should follow some norms which are very, you know, healthy, to prevent this disease. You know, administration is facing challenge on how to deal with numerous violations of home isolation, because violations are in the form of clearing of stickers denoting the isolation term. Many positive people are stepping out of the homes during quarantine period, and they are supposed to respond back to the call of the you know, health authorities, but they are not responding. So these are, you know, the challenges which you know, authorities are facing, and our role is very important in this manner. No, instead of penalizing these people who are not following the norms, now the, you know, stress is, you know, making them you know, doing the counseling. Okay, if they are not behaving in such a way, then how their you know, negligence can make other people affect, and how the seriousness of pandemic will be more and more. Next, please. Next slide, please. So, how one can help in containing the disease? Naturally, all these things are, you know, community is very well aware. One can help in following good personal hygiene, by hand washing, or by following tough etiquettes. And one can also avoid or restrict unnecessary travels, participate in public gatherings, and ensure reasonable social distancing. But we are seeing from the media that people are not following these instructions, and many a time they are doing the wrong things, and that's really creating a problem for the government or for the country. So this can contribute greatly in breaking the change of active transmission if all these informations are followed. So as the problem of you know, mental health is concerned, virus has created a financial distress, loss of job to the breadwinner, most often the men, and even domestic and violence and abuse. So the role of you know, women who are also the caregiver for the children and elderly, most vulnerable to COVID, their position becomes even more marginalized, and they are experiencing anxiety. So here our roles becomes more important. And it has been seen that in the last union budget,
Dr. Anil, you have 1 more minute.
Okay, the budget has been cut. So additional, you know, resources have to be generated from the PM Care Fund, Cooperative Social Responsibility Fund, and other private initiatives. Next, please. Next slide, please. So migrant workers, they are also facing certain problems, and even many people, they have, you know, we are seeing it, they are doing suicides, and we should also help those people in this bad, you know, period. Next, please. Next slide, please. So, and yeah, these are the actually few IC material. You can change one by one slide. These are 6 slides. We have developed this material on coronavirus do's or don'ts, and also pamphlet on home quarantine and home isolation. And these information can really help all those people who are at home quarantine and in home isolation. So they can also follow. And this is on the website of AIMS, and anybody can go through it. Thank you very much.
Thank you, Dr. Anil. Thank you for your wonderful, timely presentation. Very well presented about the statistics as well as initiatives of health social workers and probable roles. Now we'll go to the third presenter, Dr. Anna Lena Redmaker. Dr. Anna Lena Redmaker is a social worker and from August Professor of Social Work in Healthcare at the Faculty of Social Sciences, the University of Applied Sciences Bielefeld. Until August, she taught at the Health Campus in Göttingen, Germany, and was a consultant for specialist concepts and research at the German Professional Association of Social Work in Healthcare. Her research and activities focus on professionalizing social work in healthcare, health promotion and prevention. She is particularly interested in health and its promotion of marginalized children and youth. She is a leader editor of German language journal for clinical social work. She has several publications to her credit. I request Dr. Anna to take this. Dr. Anna?
Yes, sorry. Can you hear me?
Yes. Perfect.
Yes, okay, great. Can you share my slides, please?
Okay.
So, thank you very much for inviting today. And I would like to switch the perspective today a bit on not only on the challenges we have faced too, but moreover what we can learn out of the crisis. These are aspects we're talking about in our association as well as in other countries I know about. So if the slides will come up, we can start, I guess. Just hang on a moment.
You have a PDF shared. So I'm trying to share that. It's not the slide, but let me share it.
Yeah, the PDF. Yeah,
Yes.
that's right.
One minute. I'm trying to locate the file. Okay. Yes. There you go.
Yeah, great. So please, next slide already. That's all. Can you share in full screen mode?
Yep.
That looks better, I think.
Great.
Are you trying to switch on the full screen mode?
It is in full screen now.
Good evening, sir.
Please go
Okay.
ahead.
Um,
It is in full screen mode. You can go ahead.
okay. So the slide is not in the right mode, but it doesn't matter that much. So what I want to point out is that first primary slide. This is one of the initiatives happening during the crisis. This is you all know Yoda from Star Wars movies. And with the quote, "Social work even in times of crisis, you need." And this is something happening very fast here around in Germany. That we look at the position of social work in the healthcare or in other fields of social work. So that we try to get seen in the media, seen in the public. So please, next slide. Just forget a little of for
give a little insight about the social work profession here in healthcare in Germany. We have about 55,000 social workers working in several fields of social work in healthcare. This is about, we can say, 20%. I'm working for the German Professional Association of Social Worker in Healthcare, and we are already founded in 1926. So we have a kind of old tradition and changing our system a bit over time. Right now we have 1,500 members, and we are headquartered in Berlin with 4 consultants and 3 assistants working there. So next slide, please. The problem about the system of social work in healthcare in Germany, like similar to other countries, I guess, is that there's no legal ensuring and it's perceived as the truth. So the one thing is the advantage is that there's a lot of flexibility for social workers practice. And professionalization, like flexible systems and working, but the disadvantages are as well clear. There is use of legal status in the dimension of the profession up to questions of payment, legality. Social work practice varies by region. We have the so-called federal states in Germany, and every federal state has another kind of practice, nomination. There's a lack of role descriptions, for example, professional identity and unclear contribution to patient care. This depends very much on the federal state and of the unit where social workers are working. So next slide, please.
Awesome.
This is challenging for us now. Maybe I try to share. Maybe it's easier.
That would be better.
Yeah.
Yeah, that would
So
be
I
fine.
think you have to stop first. Yes, you have to stop first. Okay. So now I try. Well. Oh no, I'm not allowed. I think. I'm not allowed to share my slide.
I will.
Help me.
No worries.
I'm so sorry.
Yeah, this is
Okay.
Yeah.
Yes.
Correct.
Yes, that's correct. And one, yes, that was about the advantages and disadvantages. And one very complicated aspect is the economization in the healthcare system. So there's a kind of health market for those who can act consciously and competently for their health as co-managers. So this is where social work is working in. Social work in healthcare runs the risk of becoming part of this social market and submitting to the appeal of unconditional efficiency and permanent cost savings. This is what we are confronted right now in our practice in social work. These precarious working conditions prevent continuity, like continuity in working with the patient. Neoliberal orientation stands in the way of a life-oriented work, like the life work approach, taken together prevents professionalization. And this is one of the main aspects. And now all these aspects come together in the COVID-19 pandemic. So next slide, please. There are many diverse fields of action, and not only the healthcare system, moreover the clinical social work, like the therapeutical, psychosocial, therapeutical social work, and health-related social work and social care areas. This is all different social code books. So the law is different for all these fields, and not only that the fields are diverse, moreover the systems, logics, and the payment for those are diverse. So next slide, please. So this is a kind of some pictures out of one of the initiatives during COVID-19 crisis for social work. This is the young community for the German Association of Social Work, and they started a very big campaign all over Germany with the idea to come up more the social work profession in the pandemic. So next slide, please.
Yeah, there's someone else presenting.
Someone else was sharing the slides. Yes, I see. What happens now in the COVID-19 pandemic? The health system in Germany offers, on the one hand, good opportunities, but not benefits for everyone. This is depends mostly on the health and social inequalities. Like we know from other studies about that experiencing crisis in which the PPD dropped by at least 1% significantly reduces health later in life, especially for older people losing jobs in this period. Indicated health effects of the current infection control measures in Germany, like social isolation, homeschooling, and educational injustice, youth and unemployment among older people, and rising psychosocial problems like and mental illness are those some examples for that. So I go on and hope the slides will follow me later. Okay, and some of the psychosocial consequences now is rising health inequalities, especially among vulnerable minorities, such as homeless people, single parents, refugees, poor and chronic or mental ill persons. And this is with a big effect on the profession, of course. On the other hand, low threshold aid systems are coming to a lockdown. So a lot of the low threshold systems, which provide aid on a very low level, like street work, for example, they came to lockdown, and less focus at health promotion and prevention among vulnerable target groups we can see right now. So a bit further. One more. One more. Yes. So these are some voices, not actually to the green and that one slide. It was one back, forward. One more back. Yes, thank you. No. The green and red slide, please.
Next.
That's it. Thank you. So the working situation of social workers, these are some voices we became from our members in the association, is that on the one hand, throughout COVID-19, there was a huge flexibility of the normally very, very unflexible systems in healthcare, like easier application, access to social benefits for patients, for example. On the other hand, we had unclear information policy and rapid development, for example, about workflows, how we handle things, and so on. We heard in the other presentation as well. Some social workers say we have more time now at the patient's bed. Like we have more time for example for psychosocial counseling. But on the other hand, we have more complex and critical cases in hospital, because here in Germany, we stopped the hospital care for all cases which don't need to go right now. So a lot of that are free, and we have more cases we cannot cancel. So they are have more complex health problems.
Now your voice is breaking. Your voice is breaking. This connection.
Yes, ma'am. Yes, ma'am.
Hello. I think there's a technical error from her side, and we are not able to connect. So we will take few questions.
Susma ma'am, busy with someone else.
No, I think Anna is
Ma'am, are you?
so.
Hello. Hello. Hello.
There have been few questions in the,
Ma'am, आप online आ जाइए.
the chat
आप
box.
इतना
So I'll
disturb
take
मत
one by
करो.
one, and probably the speakers can speak on the questions. There is one question from Mr. Babu Abraham. Can Mr. Babu unmute and ask the question to the speaker? Angela. Mr. Babu?
Can you hear me?
Yeah. Yes. Yes.
Angela, I would like to ask a question regarding self-care. During this COVID-19, how the people are able to maintain self-care, especially medical social workers? Do you have any suggestion regarding that?
Ma'am, please unmute yourself.
Thanks very much, Babu, for your question. Can you hear me?
Yeah, I can hear.
Yep. Okay. Self-care, I have to say, is quite a challenge because you're very busy and lots of this is uncharted territory for us here. We've not had a pandemic since the 1800s, and knowing what's been required. I have to admit, before we started to get cases, I was really quite fearful about what was coming, as were my colleagues. We were concerned, were our colleagues going to end up being affected by COVID or worse, to die? So it was quite in your face knowing that it was coming. And what I really did at the time to look after myself is I have very good colleagues that I can talk to or seek professional supervision from. I made sure that I took good physical care of myself. I didn't see my family or my friends purely because I didn't want to take anything home. Just made sure to take all those good protective measures of, good hand hygiene, social distancing, those kind of things. And knowing, whilst it was hard, knowing that I made a difference to the families that I was dealing with gave me great professional reward, and therefore that enables me to then keep going, if that makes sense.
Thank you.
Okay. Question for Miss Angela. This is by Urusha Kulshet. Sorry, I don't spell it correctly. Miss Urusha. The question is, how much scripts are effective in communicating when compared to other medium, such as video calling? Are you connecting scripts with the recording of data? If you can unmute and talk, ask the question, that would be great. Urusha.
Hello.
Yes.
Angela ma'am, I want to ask that you said about script, so how much it is effective in communication when other mediums are there, like video calling, or if we can see our loved ones or families through different modes. And here, are you connecting scripts to the recording of data? As in social work, the recording of data is also very important.
I'm not sure I'll try and answer this the best I can. The scripts that were written were in relation to compassionate conversations, so that the medical staff, if they had to make telephone calls to communicate bad news, that they had an idea and were able to think about what was their intention in making that call, what was the message that they were trying to communicate, and that some compassion and empathy was evident as well, which might sound fairly basic, but a lot of people can miss the mark when they're really focused on trying to deliver a certain message and making sure that gets out. So the scripts really were there as a preparation tool rather than actually being used so far. We've been able to do a lot of video calling and telephone work, and that's really become, it's not new technology, but it feels like through the pandemic it's revolutionised my practice and that of the people that I work with to be able to use that technology. I'm not sure what you mean by connecting the scripts with the data, recording of data.
Ma'am, recording of data means as in social work, we do report writing. So are you saying scripting is a kind of report writing?
No, a script is in like, if I was to be in a movie, I would be given a script to learn lines to say what needs to be played out in that movie. And so these scripts were for doctors to be able to give them a guiding point to have compassionate conversations with medical staff. So it wasn't about recording in the medical record. It was about how you communicate with people over video link or telephone when you can't actually see them face to face.
Okay, thank you, ma'am.
Thank you. That's a question for Dr. Anil Goswami. Sir, how does the Indian healthcare system working with the World Health Organization to deal with the COVID situation? By Debolina Banerjee. You can come online.
Well, thank you, ma'am. Actually, all the standard guidelines are provided by the WHO. So, Indian government is also following whatever is the latest research or latest development. They are also following in their day-to-day service or day-to-day research activities. Maybe different scales or maybe different, test updates or maybe new messages, whatever we are receiving from the foreign countries. This is all through the WHO, and whatever is required, though we are also following our ICMR guidelines, because they are developing by seeing all the socio-economic demographic aspects of Indian scenario. So ICMR guidelines as well as WHO guidelines are also being followed by our medical professionals or healthcare professionals.
Yes. Thank you, sir. There's another question by Olumi Roy. Olumi Roy, madam, can you please unmute yourself and ask the question? She has a number of questions. I thought that she probably can ask.
Yes.
Yeah, my question is for Mr. Goswami.
Okay, madam.
social worker, professional social worker can do something for those who are having suicidal thoughts. So what are the steps taken by professional social worker for those people in India? Because we can see numbers of these suicidal attempts are increasing day by day. What are the social workers doing?
Well, the figures which I have given, it was prior to the COVID pandemic. But this is all true because you all know that the number of psychiatrists or number of the psychiatric social workers or the counselor in India is very limited, very less. And many of our professionals, because their demand is very high in the foreign countries, and they are migrating abroad. So naturally, we have to train these type of counselors or psychiatric social workers more and more, so that more and more areas or more of the problems of the people, these can be covered. Because everywhere throughout the country we are not having mental health services at the block level or at the district level. That's why, because and there are certain other reasons why people are committed suicide. There are maybe financially or maybe socially or maybe some regional variation may also be there. So this is really a problem, and I think now we have got a new act of mental health act we have got, and we are expecting in near future it will be very effective, and we will have more and more professional health professionals who are trained in this particularly psychologically or mental health.
Okay, sir, one more question for you. Again from Guru Shah. The question is, the scope of medical social worker is not as likely in the cancer setting. What would be the reason? Summary of the question. Medical social work role.
Pardon?
Sir, there's a question.
Hello.
Hello, can you hear me?
Yes. Yes.
Yeah, the scope of medical social worker is not much in India as compared to the Western countries. What could be the reason? And what steps can medical social worker take up to grow its scope in India?
Sorry, I couldn't listen you properly. Your voice was not reaching me.
So the scope of medical social work. Can you hear me, sir? Am I
Yes.
audible? Dr. Kirti, am I audible?
The question is on the chat box.
Yes, in the chat box. By Guru Shah. 611. It has come in 611.
611.
हेलो हेलो हाँ हमारे मोबाइल पे बात कर रहे
All right.
Dipanjani Bhattacharya's question?
No, Guru Shah Kulshetra's question. The question is, sir, am I audible to you, sir, Goswami sir?
You are audible. Yeah.
Question is, yeah, the scope of medical social worker is not much in India as it is in Western countries. So what do you think could be the possible reason behind this? And what steps can the medical social worker take to grow its scope in India? And the second question which she asked is, just a second. The second question which she asked is, do you think the medical social worker in India know their roles and responsibilities that they need to perform in different settings and at different levels of healthcare, that is primary, secondary, and tertiary level of healthcare? Over to you, sir.
Well, this is true that we are not having enough professional in our field. As you know, this profession is not very old. When I got admission in 1977, nobody was knowing what is this profession. I think I was in the second batch of social work in Delhi, in Jamia Millia Islamia. And actually, many of the untrained people, they call themselves social worker. So I think everybody in India, if he is helping someone to cross the road, he says he is a social worker. So we want to make the recognition of professional social work, and we don't have so many school of social work in India, and many a times now the government is giving more and more importance on open school learning and correspondence courses. And I think when you are going regularly to some social welfare agencies experiencing direct problems, then you are learning to a great extent. And there's no doubt, even our government is not having sufficient funds as far as to solve these problems. Maybe in urban cities or in metropolitan cities, the facilities are more. At the primary, secondary, or block level, I don't think there are medical social worker posted under our own scheme or under our primary, secondary level, health facilities. Even if it's available at the district level, I think that is enough right now, I can say. But there's no doubt at least at the block level and district level, medical social workers should be available. And one thing more, you asked me whether our medical social workers are well trained to be posted at all the levels. I'll say it's not. They have to learn, and that's why that was the reason why we created this platform. In 2000, before 2009, there was no platform for the medical social workers where we can have some interactive session, and where we can learn from the different medical social workers, where if he's working in cardiology or in orbo in other department, what they are doing and how they are experiencing. Now, because of our association, we have conducted about 6-7 conferences. Many people, more and more people have really started participating in these, and they have come to know what is the role of various or different social workers in their field, and other people are also learning. So I think this is one of the way. But even at the academic point, I'll request Dr. Anish, because now at AIMS, if I give example, there are more than 20 departments where medical social workers or MSSs are posted, and the real role of every MSS or medical social worker is different. So these have to be actually taught at the institution level. So I passed my MSW in 1979, so I don't know what is the present curriculum being followed at the institute level. Thank you.
So, Dr. Anish, sir, your mic is on mute mode.
Thank you very much, sir. There are a couple of questions more in the chat box, but since the paucity of time, shall we go forward to the next level? I'm sorry for some of the questions. We will definitely have deliberations on these questions in future. I take this opportunity to thank all the speakers who have very well portrayed the role of medical social worker from three angles, from a German perspective, from Australian perspective, and also from Indian perspective. And it provoked our thoughts with regard to the role of social workers, how frontline we are working, how much we have been celebrated or we have been recognized for our work, and challenges in front of us, which was found to be uniform across all these three countries. Established countries as well as India, we specifically faced because of a lack of a licensing system. But the roles remains to be similar in terms of micro level interventions, where we focus on counseling and psychosocial support. And also the roles are there in macro level initiatives, especially in India. We have a lot of possibility even in preventive and social medicine. And recently I found a literature which has extensive information about public health social work, which is an upcoming field of practice where social workers can work in the scenario of public health. And the Council for Social Work Education, USA, has put up a big document information source on the website to share information about public health social work. You can all Google it out and find it out. So, means social work is emerging in both in hospital setting as well as in public health scenario. We need to work together to bring up our profession to the greater heights. And I really appreciate the effort taken by Dr. Anil and his counterparts in terms of establishing an association for professional social workers or professional medical social workers in India. And we are really happy from the Kerala Association of Professional Social Workers to all hand with the in terms of organizing this international panel discussion. Now over to Dr. Kirti for the next proceedings. Thank you. You're mute, Dr. Kirti. You're mute.
Yeah, am I audible now? Yeah. Thank you, Dr. Neil. Now I'd like to invite Dr. I.P. Varugi, General Secretary, Kerala Association of Professional Social Workers, for concluding remarks. Sir, please.
Hello, good evening, everybody. I hope I am audible and visible. Thank you for this opportunity. We could hear from Ms. Inchila, Dr. Anna, and Dr. Anil Goswami. Of course, situation in Australia may be comparatively better. That's what we all hope. Since the profession is more recognized in that area. And really, it is great to note that there are 55,000 social workers working in the health sector in Germany. That's a good news for all of us. Though they are facing lots of problems of identity and other role clarity. Now in Kerala, as the social work is concerned, we are very much involved in this COVID situation, especially in the fields of providing psychosocial care for different population, especially to the elderly population, to the migrant population, and the people in quarantine. And this is one of the challenges we are facing also is that the government is not properly inviting the social workers as such. They are giving general aid, and we social workers are volunteering. Except for the migrant population, there the social work profession was identified by the chief minister himself, and we have also initiated help desks in many districts, so that the people can contact our help desk and for getting all the support services. Also, we started one day, one donor blood donation campaign, uh, especially to still. What I feel the real problem is yet to come, because uh, many of the social workers are working in the unorganized sector in NGOs are likely to lose their job. So that will be one challenge. And another challenge is addressing the problems after COVID. So this will be two major challenges we all social workers are likely to face across the globe. It's not only in India, Australia, or Germany. It will be everywhere. So I think it's time that we should start thinking about how to address such type of issues. And Mr. Anil Goswami, your rich experience right from 79 onwards. Actually, the universities must be able to utilize your experience, expertise while preparing the curriculum. So that, because in India the medical social work is not yet popularized, but the people like you can contribute a lot in this one. That's what I feel. And I congratulate Aftab Alam and Dr. Kirti for coordinating all these things, and the CAPS, Kerala Association of Professional Social Workers. We're really delighted to associate with All India Association of Medical Social Work Professionals, South Zone, in organizing this great event. And let's continue in more association so that our profession gets benefited and developed. Thank you, and good evening to you all. And one more word, Dr. Anish. Dr. Anish is our Vice President who is moderating this particular session, and he is also in charge of the CAPS Skill Academy, which is offering lots of webinar series, training series, and other informative series. He is one of our rich resource also. Thank you, Dr. Anish, for all your contribution to this conference.
Thank you, sir, for your concluding remarks. Now, moving on, I would like to invite Mr. Aftab Alam Shah, convener for the vote of thanks. He is a brain behind today's webinar. He is among the founder member of AIAMSWP and also a current Zonal Secretary, South Zone. He is at present Medical Social Service Officer in AIMS, New Delhi. Over to you, sir, for the voting.
Thank you, Kirti. Thank you, Kirti. Voices are here. Thank you,
Yes,
Kirti. I, on the behalf of All India Association of Medical Social Work Professionals, extend my sincere vote of thanks to eminent speaker, Dr. Anna, Angelina, Dr. Anil Goswami, who, regardless of different time zone, come on a common platform for gracing your work and sharing with us your view today. It was a great learning for all of us to get exposed our various strategies and global front, which is enhance our knowledge, attitude, and skill. Initially, I would like to thank our President, All India Association of Medical Social Work Professionals, Mr. B.R. Shekhar sir, for his continuous support uh, and endless motivation, without whom planning an international panel discussion would not be possible. I extend my heartful gratitude to our General Secretary, All India Association of Medical Social Work Professionals, Dr. Anil Ghosh, Dr. O.P. Giri sir, for your motivation and support. I give my special thanks to Dr. A.P. Varghese, General Secretary, Kerala Association of Professional Social Workers, for cooperation in organizing this program and valuable support. I also thanks to give the opportunity. Thanks to Dr. Anis, person of the day, Kerala Vice President, Kerala Association of Professional Social Workers, for his continuous support and multi-dimensional coordination for success of the seminar, without whom it would not have been possible. He is an asset for our organization and profession also. My special thanks to Dr. Narendra for his constant support and coordination for handling technical aspects. I also appreciate him for his innovative idea regarding conducting webinar series. At the last, I am also grateful to our co-convener and host of the panel discussion, Dr. Kirti Arya, for being available 24/7 by my side and facilitating me each and every area for successful implementation of the panel discussion. Our thanks to all the participants for their interest and active participation, and look forward to their meaningful learning experience. With these warm words, kind message, we move on the end of the today's seminar. Thank you everyone for marking your presence. Thank you. Wish you a safe and good health, all of you. Thank you.
Thank you, Dr. Aarti and Dr. Anis. We would like to see your, Dr. Anis, we would like to see your smiling face once again in near future. And special thanks to Dr. Aarti and Mr. Aftab for creating such a situation. Sorry, Kirti Arya. I just forget to.
Thank you, sir.
So it was really a nice experience, and we wish such interactive program we should continue in near future with the different topics, and we should make it a regular feature. Thank you all.
Thank you all. I need to convey the message from Dr. Anna. She could not join back because of some technical difficulties over there. She really informs all your wishes to you all. Thank you, Angela. Thank you, Dr. Anil Goswami. Thank you, Aftabji. Thank you, Kirti. Thank you, Narenji, everyone for this wonderful organization. Shekhar sir. And there will be a lot of veteran social workers in this group, including Dr. Jayachandran from Srijitra Institute. He retired from the Srijitra Institute. And I found Sanjay, Dr. Sanjay from Delhi University. All people, all senior people in the group. Thank you all.
Thank you, everyone. The feedback link is shared in the chat box. So are you sharing the feedback link in the YouTube? Dr. Anil?
We haven't shared in the YouTube.
Okay. So
Karanji,
are we?
will you be able to share that in the YouTube?
I have already shared. No issue.
Yeah.
Yeah.
Thank you. Thank you.
Okay, yes. Sir. Okay, thank
We'll
you.
keep it open for another 10 minutes. So people want to register, keep do that. They can do it
Yeah.
on
Yeah.
YouTube also.
Yeah. Yeah.
Sorry.
Yeah. Yeah.
Thanks, Narendraji.
NB Singh
Okay.
ji,
Bye,
Thank you,
sir.
everyone.
Thank you.
Bye. Bye. Bye.
Bye. Bye,
Hello.
Miss Angela. How are you?
Thank you.
तो 10 मिनट बोला है चलने के लिए 10 मिनट चलेगा ये बोला कि फीडबैक
Bye, everyone.
Bye, Dr. Anish. Thank you.
Bye, bye, bye.
Bye, bye.
This connection has made us mistake. This happened.